For the next case, we have a 69-year-old gentleman, Mr. Ng, with past medical history of fatty liver, presented to us with altered bowel habit for 6 months. Fecal occult blood was positive, and patient has normal hemoglobin level. Colonoscopy done in November shows multiple 3 to 8 mm sessile polyps from ascending to descending colon, and also a 15 mm pedunculated nice 2 polyp at sigmoid colon, and diverticular throughout the colon. That is the sigmoid polyp. Professor Lau will be demonstrating to us AI-assisted colonoscopy plus or minus polypectomy plus or minus underwater EMR, commentated by Professor Sano.
Hello.
Hi, good morning, good morning.
Professor Sano and Louis.
Welcome.
Hello, good morning. I'm very honored to have a dream team here and also a large crowd. So Professor Sano will be my commentator, and together with Dyson and Naoki. And we also have our dream team of nurses, Candy, Clive, and also Penny, and also our anesthetist friend, Calvin. So welcome. So we move from fluoroscopy to endoluminal. So today we are going to demonstrate the colonoscopy with AI assisted. And the model of colonoscopy that I'm using today is the X1 system, the latest Olympus system with a much clearer quality of the images. And the colonoscope that I chose today is the XC 1200 scope. So it has a zoom function together with all the X1 features. So we are in the cecum already. So now we can see this is the white light endoscopy. And then, of course, we have the narrowband imaging functions. And then for the X1 system, there's another additional feature is the texture enhancing TXI mode. So you can see the contrast between the red and white more clearly. And I guess most of you can already spot the lesion, a small lesion here. But I think when we turn on the white light, it may be easily missed. So there's some advancement in the technology nowadays, which is the AI-assisted colonoscopy, which has been shown to increase the adenoma detection and also reduce the adenoma missing rate. So why not we just turn on the AI now? Target mode. Yes, so now we are using the Olympus AI system paired with the X1 system, which is called the Endo 8. So there are 2 modes for Endo 8, and this mode is the more commonly used one will be a target mode, which you can see on the screen. There's a green box highlighting the abnormal lesions that may alert you for further treatment or characterization. So because we see the lesions, so now we are going to characterize the lesions. So I switch to the narrowband imaging row. And then we use the zoom function. You can see very clearly the overall patterns and also the vessel patterns.
So, Luis, so the AI End8 work under the NBI?
Usually it works on white light endoscopy only for now. But we have a much better detection now, so we would like to characterize the lesion. So Professor Sano, what do you think about this lesion?
Yeah, so how about, but this lesion, you know, this scope is 1200. It has a high resolution, much improved compared than the previous colonoscopy. So that you can see the brownish capillary, but this is almost a normal light capillary, and surface pattern is brownish, whitey surface pattern can be seen. But we can see the black dot on the surface.
Yes.
And the regular surface pattern can be seen. So I think I guess that this is hyperplastic, but maybe located in the cecum bottom, and some opening is showing heterogeneous, some parent crypt orifices are enlarged.
Yes.
So I guess that this is like a sessile lesion.
Yes, I agree with you, because I also can see the type 2O patterns and also some brown crypt opening. So maybe, especially this is located at the cecal area, so this is probably the SSLs. And it again shows that these lesions can be easily missed by our human eyes, which can be potentially neoplastic, but with the help of the AI, so we have the chance to pick up these potential missed lesions and probably may potentially reduce the chance for interval cancer.
How is so specificity using Endo-8?
Yes, I think for this is an upgraded version for Endo-8. So they increased the training data, and you can actually see that the false positive rate is rather lower than before.
Okay.
So it's quite specifically highlighting the abnormal area rather than like flashing around the screen. So I think this new version may be a better version already. And of course, we look forward to an even stronger version, including those really flat and sessile serrated lesion detection, because these are the keys to reduce the missed polyps, I think.
Yeah.
So Sano Sensei, how are you usually going to treat these small lesions?
Yes. So this is very so tiny. There's some fiber inside. So I try to perform the cold snare polypectomy.
Yes, let's use the cold snare polypectomy. So the snare today I'm using is also the Olympus Snare Master. So a special feature for this snare is it can use together for hot and cold snare together. So in the view of a green endoscopy, we try to save different waste from the polypectomy. So this snare has
Louis, before you perform the polypectomy, may I just comment that up to now the characterization of SSL, sessile serrated lesions, has not been validated to be accurate enough, because most of the AI assisted colonoscopy detection of polyps are based on adenoma instead of SSL. So we have to be a little bit cautious about relying on that as a characterization of the lesion.
Yes, Professor Song, thank you for your comment. I fully agree. Actually, the training data of SSL is still rather minimal in different AI models. So we always need to train ourselves, not only looking at the box that was highlighted by the AI, but instead we look around the whole screen in order, because after all, we are more important to train ourselves as a human eyes. For the characterization just now, we still stick to our basic principle for MBI by using the WAPS classification, by looking at those mucus, irregular border, and also the brown crypts. So we think that this can be a SSL based on our MBI assessment.
Because so the histological criteria for SSL is changing in 2019, so that it makes it more difficult to diagnose.
Yes, I agree. The histology diagnosis is one abnormal crypt. So for cold snare, there are a little bit tricks, because on the contrary with hot snare, we try to grasp the lesion upwards to avoid mural injury, but for cold snare, we try to push a little bit downwards in order to capture more mucosa like this, then cut. Yes, and then for most designated cold snare nowadays, they are very good at these cold cutting. So and also the safety of cold snare has been well demonstrated, even in patients on anticoagulants.
What kind of retrieval device do you use?
We use the trap with the suction.
Suction trap, okay.
Yes, so we try to suction the lesion into our channel. Sano Sensei and I found another bigger one by the AI, and also by us, of course. So this lesion has some stalk. So, Sano Sensei, do you have any recommendation for removing these 1P lesions?
Yeah, 1P lesion has some thicker vessels into the stalk. I usually use snare with coagulation current. And this is a 1P, but the stalk is very short. So that I think once a cut using a snare and then apply the clipping.
Yes.
To prevent the bleeding.
Yes, I agree.
Yeah.
So how about the characterization
Sure,
of this lesion?
As you can see, the surface pattern, the oval and tubular-like surface pattern can be seen. And the other is a bezel as well. There is no irregularity. So that JNet2A, this is a adenomatous lesion. There's no invasion site.
No invasion. So we can safely perform snare polypectomy.
Agree, support. So do you want, usually, do you inject?
Yes, maybe
saline?
usually I will inject a little bit saline at the stalk, and then we can demonstrate the difference between the cold snare and hot snare.
All right.
So let's inject some saline first. So now I switch to TXI mode as well. So you can appreciate the difference between the contrast and also the color.
I think left side, upper left side is showing some irregularity. So that I think this is some component of the high-grade dysplasia.
Let's have a look over there.
This area. So as you can see, some irregular bezel can be seen at the edge of the surface pattern. So showing some irregularity. So that this components are showing the high-grade dysplasia components.
Yes.
And the other is a low grade.
Yes, I agree. But I think the high-grade component is at the head, so we can still safely remove it en bloc by simple polypectomy.
Sure. Yeah.
Injector.
So it seems that, Louis, you are very familiar with all these target boxes. So I think some endoscopy may find it disturbing while you are doing the intervention, but you like to still, put on the target mode still with...
Yes, I think, no problem with me. How about you, Sano Sensei?
Now, so turn off the target mode.
Okay, let's turn off it.
We don't need it. No. So do you use some epinephrine?
For now, I just use the saline. Let's keep this mode. There's another mode that can be less disturbing to endoscopists. Apart from target mode, the AI also has another mode for normal mode.
So snare, please.
Yes.
Snare.
Yes. 另外一個mode. Okay, another mode.
What kind of the solution? Normal saline?
Normal saline. Okay, never mind. Let's do the snare. So as I just said now, we are using the same snare, the snare master, because this snare can perform both cold cut and also hot snare polypectomy with the same snare. So we do not have to open two different snares for one colonoscopy. So kind of more cost saving and also more environmental friendly.
It's important.
Open. Okay, not sure if big enough. Yes. Okay, close. Okay, so usually after closing, I will check whether I grasp the tissue. And apart from capturing the lesion by also preventing mural injury by injection, we also add a little bit trick by moving away from the muscle layer. And then we can apply the cutting current. Okay. So, we have some bleeding now, so we have something to show now. So we have RDI mode by this X1 system as well. So because there are probably two main reasons. First is less anxious for the endoscopist by this amber color. And secondly, actually, personally, I also use this mode a lot in ESD. We can actually find the bleeding point very accurately. So you can see the bleeding point is actually
from light side?
From the 3 o'clock. From the 3 o'clock.
3 o'clock.
Yes.
We can see clearly.
Yes.
Switch normal mode. Please switch normal mode.
Yes. So this is the normal mode.
So very stressful. Yeah, very stressful.
Yes. So less
stress.
Less stressful. So now we are trying to clip the bleeding.
All right.
So the clip I'm using today is the latest new version for Quick Clip Pro from Olympus company as well. So it's not yet launched in Hong Kong. So
what does it mean latest? What does it mean?
It's the new version, updated version of Quick Clip Pro. So the unlocking system and also the clip design has a little bit upgrade.
Okay. So let me
yes. So please open the clip. So this is a 11 millimeter Quick Clip Pro 2. So maybe you can rotate a bit to show the audience. You can see the rotation is quite very smooth and yes. So you can adjust the rotation very smoothly.
Oh yeah, very smooth.
Yes, and then yes. By doing this, we can actually like position ourselves to the exact position that we want. Fire. Yes, and they have an upgrade for the firing mechanism as well, because if you know the previous Quick Clip Pro has a hook. Sometimes maybe a bit difficult to get rid of the hook after firing, but this time with the new design, then you can see the firing is quite smooth, as smooth as the other clips.
So there's no need to release the hook.
Yes, because
very important.
The old Quick Clip Pro has some problem with the releasing of the hook. So the new design has improved this problem. We may need one more.
Yeah, still a little bit breathing now.
Yes.
So I guess there will be many new Quick Clip Pro ready for you.
Yes.
But so frankly speaking, to ask a question about closing the defect. So what are the conditions that we consider routinely closing all this polypectomy defect?
Open. So personally, I think for cold snare, there's no need to close the defect at all, because it's proven to be very safe even in anti-thrombotic patients. Fire. Yes, you can see the release very smoothly of this new Quick Clip Pro. And for the cold snare polypectomy, I seldom close. How about you, Sano Sensei?
Yes, I agree. I support.
Yes, and for like larger lesions or pedunculated lesions or with immediate bleeding, we may consider closure. But for larger than 2 centimeters, like the EMR, especially at the right side, there's actually evidence supporting the prophylactic closure, even there's no bleeding. So for us, we usually close all right-sided defect more than 2 centimeters, according to the evidence.
Yeah.